Good morning, good afternoon, everyone. Thank you so much for joining us for today's prostate cancer session of the Upgrade Oncology Pathology series hosted by ASTP and the Project Pink Blue in Nigeria. Very excited today to have this discussion of prostate cancer with pathoradiological correlation by one of my very good longtime friends, Dr. Christina Maggi-Galuzzi from UAB, who is a professor of anatomic pathology and the C. Bruce Alexander Endowed Professor in Pathology there. And she's joined by her colleague, Dr. Sam Galgano, who's the Associate Professor, Vice Chair of Quality and Patient Experience, and the Section Chief of Abdominal Imaging at UAB. This should be a really exciting discussion. I hope you have lots of questions for them, and I will turn it over to Christina and Sam.
Okay, thank you, Dan. But yeah, so I'm Sam Galgano. I'm a radiologist, and Christina has invited me to participate in this webinar, which I know is predominantly aimed at pathologists, but it is always nice to have some correlation with radiology. Next slide, Christina. We have no relevant financial relationships. And now we'll go over the objectives. So the objectives will be to discuss prostate cancer detection on CT scan and diagnosis on needle biopsy. My focus on CT scan was predominantly because did not really know the widespread availability of MRI, which we use a lot in the United States, what the widespread availability of MRI in Africa is. So wanted to make it a little more relevant. But then we will also review prostate cancer staging on CT with needle biopsy and radical prostatectomy specimens. We will discuss biochemically recurrent prostate cancer. We'll also discuss visceral metastatic disease from prostate cancer. So kind of the spectrum from very localized disease to very advanced disease. So we'll start, I kind of did mine as a case-based to kind of set the stage for Christina. So this first case is a 64-year-old male who presents to the emergency room with epigastric pain, and this is a contrast-enhanced CT through the prostate gland. And if you look very closely, you can see where the arrow is pointing. There is a focal area of enhancement that looks different than the rest of the peripheral zone. So the central gland does enhance, like BPH tends to enhance. But here in the peripheral zone, we see something that is focally enhancing where the arrow is. And so this focal enhancement should not be ignored. And this is suspicious. It's not definitive, but it is suspicious for prostate cancer and should prompt a workup. So that is the focal enhancement. So going on to the next slide, to briefly discuss kind of CT scans or findings on CT for prostate cancer that's localized to the prostate. So Christina, you can start clicking. So this was the patient's biopsy that subsequently happened. And you can see here, this does prove that they indeed had prostate cancer in the region of concern, among others, but pretty much on the left side of their prostate gland where that enhancement was, they did have prostate cancer, both Gleason 6 and 7. So talking about detection of prostate cancer on CT scan. So we know CT is commonly performed, at least in the United States, for multiple complaints. And so, can be performed for prostate cancer, but most of the time it's actually performed not for prostate cancer. But we should pay attention to the prostate on it because it is an extremely common cancer. So it is important, especially on contrast enhanced exams, to evaluate the prostate for potential pathology, regardless of the indication for the CT scan. When we do CT scan for staging of prostate cancer, it's okay. It's actually better for staging or detecting nodal and visceral metastatic disease. We know we look for enlarged lymph nodes. We know we look for hepatic metastases. We know that CT offers us less soft tissue resolution than multiparametric MRI. So that's why, if available, MRI is sort of the modality of choice for evaluating the prostate gland itself. But in terms of staging people, per guidelines by the NCCN, we often do CT scan of the abdomen and pelvis combined with a nuclear medicine bone scan, which is known to detect osseous metastatic disease, to comprehensively stage these prostate cancer patients. Diving in a little bit more about how does CT perform for prostate cancer. So kind of like in this case, on CT, prostate abnormalities or true prostate abnormalities generally present as circumscribed mass-like enhancement. So not diffuse, kind of like we saw in the central gland, but more focal like we saw in the peripheral zone on that. The ability for CT to detect prostate cancers really does depend on where the prostate cancer would be within the gland. As you might guess, it is for the transition zone and central gland, it is almost impossible to differentiate true cancers on CT from BPH nodules. And that's why CT, generally speaking, is not the modality of choice for imaging the prostate gland if we have it. But while insensitive for the detection of prostate cancer, focal suspicious lesions on CT do strongly correlate, like in this case, with true underlying malignancy.
Thank you, Sam, for setting the stage. And now I will try to cover, use this case to cover the pathological correlation. So as Sam mentioned, this patient had multiple core biopsy on the left side that were positive. This is one of the example of the left base biopsy that you can see here highlighted. There is a focus of very crowded glands, then was stained with P63 and is completely negative for basal cell marker. So this is an example of prostatic adenocarcinoma, Gleason score 3+3 = 6, equivalent to grade group 1. And I will use this case to discuss few key important features in making a diagnosis of prostate cancer. The first one being, of course, the lack of basal cells that is highlighted also in this case by the negative staining for P63. You can see a small focus of crowded glands on the left side of the screen. Those glands are negative for P63, and a deeper level shows also additional glands that are negative, and they're staining diffusely for AMACR or racemase. But again, the most important marker is the lack of basal cell marker that is a key diagnostic features, although by itself is not, of course, the sufficient one, but in view of the morphologic features, this is diagnostic of prostate cancer. Now, just to review, this is based on a best practice recommendation, was published in 2014 by the International Society of Urologic Pathology. The use of different stains that are important in making a diagnosis of limited prostate cancer. You can see that P63 is the more specific one. You need to be aware of the fact that one of the disadvantages that there is a P63 positive aberrant prostate cancer. This is a tumor that expresses P63, but in a non-basal cell distribution. Other markers can be used depending on different laboratory, like high molecular weight cytokeratin is also a good marker, but the sensitivity is less, but there's increased non-specificity. Sometimes those two markers are used together. AMACR, of course, is a positive marker, so it's positive in 80 to 90% of prostate cancer, but it's important to know that there are also false negative in mimickers, like benign entity may focally express AMACR, in particular adenosis and partial atrophy. And the cocktail, of course, is the most important and widely used marker. Is used as a PIN4. This is important to conserve tissue, and you have the dual color, so you can, in the same slides, look for the lack of basal cells and the presence of AMACR. And briefly, I want to mention ERG. ERG is very highly specific for prostate cancer, although only positive in 40 to 60% of cases, and can be positive also in high-grade PIN. So it's not commonly used in the diagnosis of small foci prostate cancer because it may be positive only in less than half of the cases, but when positive is very helpful. The other biopsy from the same case, from the left mid, showed actually another area of prostate cancer. But you can see here, in addition to these well-formed glands, there are areas where the glands are more like poorly formed or fused. So this is an example of prostatic adenocarcinoma, Gleason score 3+4 = 7, or grade group 2, where the Gleason pattern 4 represent about 5% of the tumor, and cribriform pattern 4 is not identified. This is the way that we report our biopsy. These are important information that the clinician will use in assessing what is the best next step for these patients. And it gave me the opportunity to review briefly the evolution of the Gleason grading system. Now, you can see here in the comparison between the left side of the screen was the 2005 ISUP modified system and the 2014 ISUP modified system. That is the one that we're currently using. In the past, small cribriform glands were included in Gleason pattern 3. Now, since 2014, all cribriform glands are included as Gleason pattern 4, and only small well-formed glands or branched glands are included in Gleason pattern 3. And you can see here an example of what we would include in Gleason pattern 3. The glands are well-formed, individual entity. One could count them if you decided to and you have enough time in your hands. There may be variability in size and shape, and also microcystic and pseudohyperplastic cancer would be included in Gleason pattern 3. Branching glands, like seen in here, some irregularity, are allowed in pattern 3 as far as you can have a distinct border of each individual gland. There's been also an evolution of Gleason pattern 4, of course, with the restriction of what we allow in Gleason pattern 3. Gleason pattern 4 has been expanding. In the past, you can see there were large cribriform glands, ill-deformed glands or poorly formed glands, and fused microacinar glands, and these hypernephroma-like tumors. This entity has been crossed out. Currently, the Gleason pattern 4 includes 4 different patterns: cribriform glands, both small and large, fused glands, poorly formed glands, and glomeruloid glands. And here's an example showing all these entities. In the upper left corner is an example of a large cribriform glands. In the upper right corner is example of fused glands, where you can see it would be impossible to count these glands because they're fusing the borders and there's no stroma in between those glands. In the lower left corner, there are poorly formed glands that you can see here like cording. And the right lower corner, this is an example of glomeruloid structures where you can see these like cribriform-like aggregates of glands that are floating within a space that is a glandular space. And the only way these glands are attached is with one portion of attachment at the edge of the cavity. So the evolution of Gleason pattern 5 has not been dramatic. There's not been major changes. These are the different entities that are included in pattern 5. Small solid cylinder based, as you can see on the right side of the screen, the fact that there are no basal cells. So these are included as Gleason pattern 5. The presence, of course, of single cells, solid sheets, solid to medium large nest with rosettes, and the presence of unequivocal comedonal necrosis. But you can see that this is an italic because I want to bring up some point for discussion. So here's an example of signal ring-like prostate cancer. This is graded as pattern 5. Single cells graded as pattern 5, and an example of rosette-like architecture that is also included in Gleason pattern 5. As I mentioned, comedonal necrosis was in the past included for Gleason pattern 5. However, you need to be aware that there are some lesions like this one where you have comedonal necrosis, but actually, if you pay attention at the periphery of this large nest, there are actually basal cells that can be identified with stains for basal cell marker. So this is an example of intraductal carcinoma of the prostate. And there's a couple of studies, one by Memorial Sloan Kettering, Samson Fine and his colleagues, and one by Madden et al. That were published where these large glands with comedonal necrosis are not always, but commonly represent intraductal carcinoma instead of invasive prostate cancer. So I want just to use this image to remind you that the routine assignment of pattern 5 to lesion exhibiting comedonal necrosis should be reconsidered. And before using comedonal necrosis to upgrade a case to pattern 5, you need to make sure that you don't have basal cells at the periphery of these large nests, and that area represents just intraductal carcinoma of the prostate. To summarize the Gleason grading, we have discussed the pattern 3 with well-formed glands, the 4 different patterns of pattern 5, cribriform, fused, poorly formed, and glomeruloid, and also the Gleason pattern 5 with solid sheets and single cells in addition to the solid cylinder. As I mentioned during the report for that case that we presented, we use also the grade grouping system. This has been introduced and originally in 2013, but then it has been advocated by both the International Society of Urologic Pathology, CAP, and also is included in the synoptic report and WHO. And usually we report both the Gleason score and the grade group system. Now, this has had a major impact. First of all, provides a clear label for patient understanding. And based on the grade group system now, the lower grade group risk group of patient is grade group 1. These are tumor with Gleason score 3 + 3 = 6. And also based, and I'm going back here, you can see that now the Gleason score 3 + 4 and 4 + 3 are divided in 2 different grade groups, group 2 and group 3. So this allows a better discrimination between these 2 groups, where the grade group 2 is still active surveillance eligible, but the grade group 3, 4 + 3 = 7, is not active surveillance eligible, at least in the United States and in most cases. There are some exceptions depending on patient age or morbidity. So this grade group provides also greater discrimination in terms of prognosis than the traditional Gleason classification. This has been shown in multiple studies where you can see both in radical prostatectomy, but also in cohorts treated with radiation and with patients treated with active surveillance. There's a very good discrimination between group 1, 2, 3, 4, and 5. Much better than would have been done with just the Gleason scoring. So we mentioned a few things during the conversation in terms of Gleason grading. Now I want to focus your attention on unfavorable pathologic features that we recognize in our pathology report: the presence of cribriform pattern 4 and intraductal carcinoma of the prostate. The distinction between these 2 is based on the absence of basal cells, because both entities have a prominent cribriform or dense architecture. But in the invasive pattern 4, there's no basal cells. The intraductal carcinoma of the prostate retain basal cells. This is another example where you can see in the left side of the screen, there is cribriform pattern 4 with perineural invasion, lack of basal cells, compared to the right side of the screen where there is a cribriform, dense cribriform architecture, but the basal cells are present at the periphery of this large gland. So intraductal carcinoma of the prostate is a proliferation of malignant secretory cells that are growing within, and they expand these prostatic ducts. Most of the cases represent a retrograde spread of prostate cancer into prostate glands. Like in this case, you have the invasive component, and then the tumor also fills up retrogradely the large glands. In some cases, maybe a precursor of prostate cancer. So those are the cases where there is no invasive component identified within the same case. There's been multiple studies showing the association with adverse prognostic features at radical prostatectomy in association with intraductal carcinoma, such as high Gleason score, large volume, extraprostatic extension, seminal vesicle involvement, and also lymph node mets. And this is also an important independent predictor of clinical outcome. That is the reason why we report both cribriform pattern 4 and intraductal carcinoma of the prostate on the needle biopsies, if present. Now, just a few words again to the diagnostic criteria. This is a spanning of large acidic ducts by malignant epithelial cells with preservation of basal cell. That's the key features. And there are a few features that are important. You can recognize 2 different categories of intraductal carcinoma of the prostate. The one with solid of dense cribriform. This is where more than 50% of the epithelium fills up the glands. Or you can have cases where you have loose cribriform, so less than 50% of the epithelium fills these large glands, or micropapillary. To make a diagnosis of intraductal carcinoma, if you are dealing with these morphologic features, you need additional features: the presence of comedonecrosis, non-focal, or marked nuclear atypia with nuclear size more or equal to 6 times the normal nuclei of secretory cells. Here's just a reminder of all these different patterns. You can see on the left side of the screen, this is a solid example of intraductal carcinoma of the prostate with the retention of the basal cells. This is a dense cribriform with more than 50 or 70% of the lumen filled by neoplastic cells. This is a case of loose cribriform where you have comedial necrosis. And here is a case of micropapillary where in addition to the comedial necrosis, you have this prominent also nuclear enlargement that you can see here at the upper portion of this microphotograph. So the presence of intraductal carcinoma should be associated or not with invasive cancer should be noted in your pathology report. Isolated intraductal carcinoma of the prostate when present on a needle biopsy should not be graded if there is no invasive prostate cancer. However, it's still controversial whether intraductal carcinoma in association with invasive cancer should be incorporated into the prostate cancer grading. There is controversies between the two societies, one suggested to include it in the grading, the other one not to include it in the grading. Now, this is just to remind you that there are multiple studies that have been published in the last 10 years or so, showing that both the cribriform morphology and intraductal carcinoma are very important features associated with unfavorable pathologic feature and poor outcome. There is association with extraprostatic extension, upgrading, positive margin, biochemical recurrence, lymph node metastasis, and also distant metastasis. And this is a nice paper that was published in 2017, including the concept of the nimbosus or constellation of poor features when tumors are not only have intraductal carcinoma, but also the presence of cribriform architectures. These tumors are associated with a much higher percentage of PSA relapse and distant metastasis at 10 years compared with patients without intraductal carcinoma of the prostate or cribriform architecture. Also, in the new WHO, there is a chapter on hereditary tumor syndrome, and I just want to draw to your attention that tumors with intraductal carcinoma of the prostate and cribriform histology are more likely to harbor DNA repair genetic defects, and also that germline testing has been advocated on patients with or without genetic counseling for patients with high-grade features, and intraductal and cribriform histology, in addition to ductal adenocarcinoma, are features that would, make sure that the clinician would order germline testing in this patient because of the more aggressive behavior. All right, case 2. Sam, you're back.
Yes, thank you. So this case is a 71-year-old male who presents for staging of his prostate cancer and undergoes a CT. And so you can see here, this is an image through his pelvis, again, a contrast-enhanced CT scan. And you could already sort of see where the arrow is pointing. There is clear asymmetry of the prostate gland. It doesn't look round or oval as usual, and it extends farther posteriorly on the right, and the whole gland, that portion seems to enhance more. And so that encroaches on sort of where we would expect the neurovascular bundle to be, even though we don't really see it well, and clearly seems to be extending outside the prostate gland. So this is an example on CT where we don't even need MRI, where we could see frank or focal EPE, not microscopic EPE, but actual EPE and neurovascular bundle involvement. And this is important, particularly for the radiation oncologists. Some additional images higher up, again, centered more on the seminal vesicles. Again, that asymmetric soft tissue on the right side of the prostate, you can see also appears to involve the right seminal vesicle. And so this is an example of right seminal vesicle invasion. In addition to the EPE and neurovascular bundle involvement. And then kind of completing our tour of the pelvis, you could see here that on the left side of the pelvis, along the left pelvic sidewall, there appears to be a pathologically enlarged lymph node that in this case, with clearly a very advanced prostate cancer, is consistent with an iliac nodal metastasis. So kind of a good example of some of the things CT can find when it comes to prostate cancer staging, even for just sort of pelvic localized disease. So this is an example of the corresponding MRI of that same patient, again, confirming all of our findings on the CT scan with the EPE on the right, the neurovascular bundle involvement, and then the seminal vesicle invasion, where we see that normally the T2 hyperintense seminal vesicles are replaced by T2 intermediate to hypointense tissue right here. So this is consistent again with what we thought we found on the CT scan. So just a good correlation between the CT and MRI, but you could see how much better on the MRI, we didn't include a lot, how much better you can distinguish prostatic tissue compared to CT. So some information on prostate cancer staging with CT. So as I implied earlier, a lot of our current practices, at least in North America and the United States, have shifted to the use of multiparametric MRI for local staging, if available, due to the superior performance, especially when it comes to assessment of extraprostatic extension and seminal vesicle invasion. We know that MRI outperforms CT in that regard. CT is relatively inaccurate for local staging. It is better at identifying seminal vesicle invasion, and some studies suggest about 69% of cases with seminal vesicle invasion can be detected on CT, which is not that bad, but obviously much, much worse for EPE, with less than a quarter of the cases accurately identified on CT. Nodal metastatic disease, we do okay on CT. Obviously, we rely on size criteria to diagnose nodal metastatic disease on CT. And we all know, particularly in the era of molecular imaging for prostate cancer, that many lymph nodes harbor metastatic disease that are not pathologically enlarged by size criteria. So this study cited here estimates an accuracy of about 72% for pelvic nodal metastatic disease. And then CT does perform well for detection of osseous metastatic disease, but a main limitation in that is that we are limited typically because we only CT scan part of the body, and in the case of prostate cancer would be the abdomen and pelvis, so we don't image the remaining osseous structures in the body. And so that's an advantage of molecular imaging, both with PET or with even a nuclear medicine planar bone scan, is that we're able to image the entire body osseous structures to comprehensively evaluate all the bones for metastatic disease, rather than just those seen on CT of the abdomen and pelvis. So to diagnose lymph nodes, typically radiologists will use a short axis dimension of 1 centimeter to be considered suspicious, but there are other suspicious features that we use to make us more suspicious when lymph nodes start to look rounded on CT scans, when they start to look heterogeneous, particularly when they enhance or if they have central necrosis. And then kind of the earliest sign that we see on imaging, both with CT and ultrasound and MRI, is when they lose a fatty hilum, but that fatty hilum can be so small that even with our best imaging techniques, it can be hard to see. For prostate cancer, common sites of nodal metastatic disease include the iliac nodes, the retroperitoneal nodes, and mesorectal lymph nodes, and we see those all not uncommonly. For seminal vesicle invasion, on CT, especially, asymmetry of the seminal vesicle in a patient with prostate cancer, particularly if there's associated enhancement, should raise concern for seminal vesicle invasion on CT. And then for EPE, microscopic EPE is basically not able to be detected on CT. And MRI is better, but it's only modestly better. MRI is not even perfect. Pathology actually for EPE is the gold standard because we know we miss EPE on MRI. But focal EPE or frank EPE with neurovascular bundle involvement can clearly be called on both CT and MRI in these advanced cases as they're not very subtle.
So thank you, Sam. So this is actually a case where the pathology actually confirms the concern that was raised in one of the imaging, that the lesion was indeed extending to involve the extraprostatic tissue. And you can see here there are atypical prostate glands that are interspersed in between fat. So there is fat at both sides of these cluster and nest and cords of prostatic glands. And also you can see here additional prostatic neoplastic glands within the fat. So this is diagnostic of prostatic adenocarcinoma with extra prostatic extension. We don't make this diagnosis very commonly on needle biopsy, but in a case like this, it is a reliable diagnosis, so that can be made. So I want to use this case to discuss a little bit prostate cancer staging. Now, this is based on the new AJCC 8th edition. And as you are aware, we do not substage T2 disease any longer. So every type of tumors that is confined to the prostate that in the past was subdivided now is just reported as PT2, independently if it's a small component of tumor, presence of tumor in one lobe of the prostate, larger portion of tumor in one portion of the prostate, or both lobes involved. It's all PT2 disease. This is organ-confined disease. Now, the presence of extraprostatic extension means that the tumor goes beyond what are the confines of the prostate. And typically, this is tumor admixed within the periprostatic tissue. This is easier to recognize, particularly in the posterolateral, posterior, and also lateral region of the prostate. As you can see here in this microphotograph, this is an example of extensive extraprostatic extension where the tumor is present in multiple areas within the fat. On the other hand, the lower microphotograph, you can see that there are prostatic glands at the same level of the fat. So this is also diagnostic of extraprostatic extension, but this is more subtle than the case above. Now, tumor within skeletal muscle that usually occurs anteriorly, of course, does not constitute extraprostatic extension. Now, the extent and also the location of extraprostatic extension should be documented in your report. Here there are a few examples of tumor with extraprostatic extension. You can see on the left side of the screen, this is tumor involving a thick muscle, neural bundle, and also ganglion. So this is a thick nerve. And you can see that there is fat on top and at the bottom of the tumor. So this is extraprostatic extension. Now here you can see that there is prostate cancer on the bottom of the microphotograph between skeletal muscle. As I mentioned, this does not qualify as extraprostatic extension. However, you can see that now there's also tumor beyond the skeletal muscle within fat. So these will be the diagnostic features for extraprostatic extension anteriorly. Here's another example of what is being described of tumor that bulge beyond the contour of the prostate. So you can see if you draw a line here, this is where the prostate would have normally ended, and there's the capsule. This tumor keeps growing beyond the capsule, induce a desmoplastic reaction, and so these glands are all bulging beyond the contour of the prostate. You can see there is fat in here. So they are beyond the level of the fat or at the same level of the fat. And similar, you have here a nest of prostatic carcinoma glands that are beyond the level of the fat. So these represent both cases of extraprostatic extension. As I mentioned, tumor within skeletal muscle, you have to be careful. This is not extraprostatic extension. This is still PT2. On the other hand, if you have tumor involving the microscopic bladder neck, the thick muscle bundle of the bladder neck, this is equivalent to PT3, so equivalent to extraprostatic extension. Now, the extraprostatic extension is usually divided into focal versus non-focal. There are different criteria. One is the Epstein criteria, the other one is the Wheeler criteria that we use. They are similar. So focal means few neoplastic glands by the Epstein criteria, or less than one high power field on one or two separate sections. So this is an example of a prostatic gland beyond the fat, and would represent an example of focal extraprostatic extension. Everything that is more than a few glands or more extensive than focal It is a little bit vague as a definition, but is non-focal. Like in this case, you can see the large nest of prostatic adenocarcinoma that are going beyond the contour of the prostate and within the fat. Why is it important to distinguish focal versus non-focal? Because there are studies showing that indeed there is increased risk of biochemical recurrence-free survival. You can see both these studies have a significant p-value between the focal extraprostatic extension and non-focal extraprostatic extension, both in the study by Paul et al. In 2015 and Young et al. With a significant p-value. So the subclassification of extraprostatic extension improves the correlation with biochemical free survival, recurrent survival. Tumor that invades the muscular wall of the seminal vesicle represent a seminal vesicle invasion. So this is an example where you can see this proliferation of neoplastic prostatic glands within the muscular wall of the seminal vesicle. This is the seminal vesicle glands and the lumen. So this is equivalent to PT3B. And this is just a high power view showing on the left side of the screen the normal histology of the seminal vesicle with the pigmented cells that you can recognize and the tumor present within the wall of the seminal vesicle. Other important things that we include in our report, of course, is the surgical margin involvement. This means that the tumor extends either extraprostatic or intraprostatic to the inked surface. And you can see here that there is prostatic glands that are present at the ink in both these cases. It's important to document the location of the positive margin and also the extent. This is done in linear length. And there are data and also the CAP guidelines requires to have an estimate. If it's less than 3 millimeter, that is limited, or more than 3 millimeter would be non-limited positive margin. Also, it's important to report the Gleason pattern at the margin, because there's a difference if the margin is positive with Gleason pattern 3 or 4 or 5. Of course, the higher grade, the more likely it's the importance of that positive margin. Lymph node metastasis or involvement. This is also something, of course, it's important for adequate staging. We also include not only the number of lymph nodes that are involved and the diameter of the largest metastatic focus. Those are important independent predictor of early biochemical recurrence. The extranodal extension is also associated with significant higher risk of biochemical recurrence and of global recurrence. Now, this has been reported in other organs. It's currently not included in the CAP guidelines for prostate cancer, but one could predict that in the future, we will be asked also to report the extranodal extension. Now, lymphovascular invasion is also significantly associated with adverse clinical pathologic features and needs to be reported when present. Here's an example of tumor that is present within a lymphovascular space. In patients with PT3A and PT3B disease, lymphovascular invasion has a 1.2 or 1.4-fold higher overall mortality in this patient than patients that do not have lymphovascular invasion. And also patients with lymphovascular invasion alone fare similar to patients with lymph node invasion alone, but patients that have both lymphovascular invasion and lymph node invasion has a worse overall survival. And these lead us to case number 3.
Thank you, Christina. So this is a 55-year-old male who presents for prostate cancer restaging. So a man who's undergone definitive treatment for his prostate cancer. And on this scan, we start to see what looks like this is a coronal image of a pelvis bone windows. So we're accentuating the findings in the bones. And what we could see in the right femoral head is a sort of peripherally sclerotic, centrally non-sclerotic lesion. There's actually a similar lesion in the vertebral body on the same image. And so that is a suspicious lesion. And in radiology, as with many things, priors are our friend. And so this was new since prior exams. So this is concerning for an osseous metastasis. And subsequently, this patient underwent a nuclear medicine bone scan, which again confirms it's kind of a much obviously more zoomed out because we're imaging the whole body, but there is a focal dot in the region of the right hip that correlates exactly to where that lesion was. So again, confirming our suspicion that this is probably a prostate cancer metastasis. And then interestingly on this patient, in looking at the rest of his pelvis and evaluating his prostatectomy bed, you can see on the left, there is asymmetric enlargement and enhancement of the soft tissues in his prostatectomy bed. And so this is consistent with a local recurrence in the surgical bed. So some brief words on imaging biochemically recurrent prostate cancer. So the historical practice includes restaging CT and bone scan once a patient develops PSA levels consistent with biochemical recurrence. And consensus definitions for that usually involve 2 consecutive measurements of greater than 0.2, a PSA of greater than 0.2. That's in patients who have undergone a prostatectomy, or in patients who undergo radiation therapy because they have variable responses in their PSA. We kind of use what their lowest PSA goes down to after definitive radiation therapy. And once their PSA is 2 nanograms per milliliter higher than that, they are deemed to have biochemically recurrent prostate cancer. So what are some features on imaging of local recurrence, as in this case, asymmetric enhancing soft tissue in the prostatectomy bed is always suspicious, but if very small, CT is not very good at it. And so it may require the soft tissue resolution that multiparametric MRI offers to detect if it's really early. The most common site of local recurrence is actually at the vescourethral anastomosis, which is a challenging area to interpret. And again, a strength of MRI is being able to evaluate that area where they hook the bladder up to the urethra after the prostate comes out. And then in-gland recurrences after radiation or brachytherapy are very challenging to detect on CT and typically require either a PET scan or a multiparametric MRI to detect. Features of osseous metastases. So typically prostate cancer metastases are sclerotic or osteoblastic. They may be subtle prior to treatment on imaging. And so sometimes after people get treated, we see what looks like development of diffuse metastatic disease. And what that actually is a treatment response and the bone remodeling, trying to get better so they become more sclerotic over time. CT is actually excellent at detecting sclerotic metastases, but the MRIs, generally speaking, may detect osseous metastatic disease before it becomes sclerotic. And so that's kind of why we use nuclear medicine bone scan, because it targets bone turnover. And so if there's any areas of bone turnover, osseous metastases from prostate cancer should demonstrate focal uptake. It is challenging on bone scan to differentiate benign and malignant uptake, particularly in degenerative changes in the spine and joints. So it does take a little bit of correlation with some of the other imaging we have to figure out, does this truly represent a metastasis or is this less suspicious than we might be worried about?
I don't know what I did. Sorry.
Oh, it's okay.
Okay, here we go. So this is an example of the pathology of the osseous metastasis. You can see here that there is the bone with some degree of remodeling, and then there is prostatic adenocarcinoma involving here the medullary portion of the bone. Similar here, you can see that there's the bone marrow on the left side of the screen, the bone remodeling on the right side of the screen, and prostatic adenocarcinoma glands that are growing within the tissue. Now, this is an example of ERG staining that was performed in another osseous metastasis. This was a thoracic vertebral lesion to prove indeed that this bone was involved by prostate cancer. I mentioned before that ERG is a very specific marker, although not very sensitive. Now, you need to know that, of course, it's positive also in vascular tumors, but in this case, the differential diagnosis was not with a vascular tumor. So this confirms the diagnosis of prostatic adenocarcinoma. Just a few words regarding treatment effect, although, of course, we did not mention the androgen deprivation treatment, but the tumors after treatment effect may have very different morphologic features compared to the pre-treatment. You can see that there's a lot of pycnotic features. The nuclei may be shrunk and small. The cytoplasm may be clearing and reduced. And the overall architecture is actually like single cell infiltrating the stroma. Sometimes you can have a lot of inflammatory infiltrate that can actually completely obliterate and make the identification of tumor very difficult. Radiation was also mentioned, and radiation treatment may induce also very prominent changes in the tumor cells. They become very, pycnotic nuclei. The cytoplasm become very frothy and sometimes look like macrophages that infiltrates with inflammatory cells. So these may be disregarded as macrophages or reactive changes, so that in view of the history, it may be important to confirm the presence of tumor cell with cytokeratin. Sometimes the degree of vascularization, particularly when the radiation effect is very prominent, make the distinction of prostatic cancer with the radiation treatment effect very difficult. Notice here that the nuclei are pushed at the periphery. They still look enlarged, but there's a lot of vascularization that may be interpreted as just like atrophy. This is case number 4.
Okay, and this is a case of a 66-year-old with known metastatic prostate cancer. And we have images here, axial CT scan with contrast of the liver, and we see at least one, but probably several round hypoenhancing lesions in relation to the rest of the liver parenchyma. And so these are concerning for metastatic disease, particularly if they're new. Typically, metastatic disease of any adenocarcinoma tends to show up as a hypoenhancing liver mass. So this is definitely suspicious. And this is a patient who underwent a PSMA PET scan to follow for comprehensive staging. And while we do see the intense uptake kind of in the liver, and it can be a little challenging because it looks almost diffuse, we see there are several spots, at least in their chest, that look suspicious for additional sites of metastatic disease. And so this is an advantage, obviously, that PET offers whole body imaging, and we know we're picking up disease earlier simply because we're not relying on size criteria. So visceral metastases from prostate cancer are next topic of discussion. After bone and lymph nodes, the lungs and liver are the next most common sites of metastatic disease from prostate cancer. So kind of like as you read for us, a lot of cancer imaging studies, you sort of learn common sites of spread and uncommon sites of spread because they help to differentiate true disease from fake outs. And so it is important to pay attention to liver lesions and lung lesions in patients with prostate cancer. Although prostate cancer, generally speaking, is still a good diagnosis, even if regionally metastatic, so pelvic adenopathy or pelvic metastatic disease, still has a 5-year survival rate that's quite high. But once distant metastatic disease forms, osseous metastatic disease or visceral metastatic disease, the 5-year survival rate drops down significantly. And that's usually because these are more aggressive phenotypes or higher disease grade or grade group compared to a lot of the other stuff that's localized to the pelvis, the more lower grade. And again, once you've reached the point of visceral metastatic disease from prostate cancer, you're almost always treated with systemic therapy. It does matter if you're deemed castrate resistant or castrate sensitive, and some of that is just how many lines of therapy you've undergone. But if you are castrate sensitive, they will typically treat you with any number of androgen deprivation agents we use here. But if androgen resistant or castrate resistant, then usually the next line of treatment involves chemotherapy. So what does the typical metastatic disease look like on CT? We kind of already touched on some of it. And so I think next is liver.
Sorry.
No, it's okay. Yes. So liver, as I said, it's a hypovascular mass. They're typically round. They're typically very well circumscribed. They don't have ill-defined margins like other kinds of malignancy. They also, generally speaking, a lot of cancers, this is not specific to prostate cancer, but may have a rim of enhancement, which kind of makes it stand out from other more benign, well-circumscribed liver lesions. Lungs tend to show up as scattered, very round nodules without a specific lobar or lung zone predilection. So there are benign processes that happen more in the upper lobes or upper lung zones, and some that happen in the mid lung zones like sarcoidosis. But metastatic disease doesn't really follow any of those rules. And so it tends to just be scattered, and the nodules themselves all are usually very round. And so the detection of visceral metastatic disease on imaging is also important. There are some therapies that we offer in the United States, one of which is radium-223 dichloride, known trademark name is Xofigo, which is given to men with symptomatic skeletal metastatic disease. But actually, if a patient who is being considered for Xofigo is deemed to have visceral metastatic disease, it may, depending on how much visceral metastatic disease they have, disqualify them from that potential treatment option. So the detection is important even when small.
Thank you. So this is an example of prostate cancer involving actually the liver. So this is a liver biopsy. You can see in the right side of the screen, the bottom portion, that is liver here, that is involved by this very poorly differentiated neoplasm. It would be impossible without stains to recognize that this is prostate cancer because it's very poorly differentiated and there's no gland formation. And actually, in some areas, one would wonder also about the possibility of a small cell neuroendocrine carcinoma. So this is just a high-power view of the same areas. You can see that these very irregular nest and cords of tumor cells that are poorly differentiated, and some are very hyperchromatic, and there's a lot of nuclear enlargement. And occasionally, you have prominent nucleoli that you can recognize. Typically, high-grade prostate cancer has characteristically prominent nucleoli. So stains were performed. So this is NKX 3.1. That is a very good marker for prostate cancer. P40, that is the equivalent of P63, was performed in this case on the outside. Pathology is completely negative. Synaptophysin negative. GATA3, and that's what I want to draw your attention, show some focal positivity. And you can see here, high-power view, that a component of this tumor is GATA3 positive. You need to be aware of this pitfall. There are actually few reports that high-grade prostate cancer can stain occasionally for GATA3, particularly when you have this high-grade and in the metastatic setting. So this is an example of metastatic prostatic adenocarcinoma with this aberrant expression of GATA3. I want to remind you of a paper that was recently published by the Hopkins group with aberrant GATA3 expression in prostatic adenocarcinoma. This is a report on 9 cases on needle biopsy. These are not metastatic setting, but they were either prostate biopsy or one was a bladder transurethral resection, where the tumor were high-grade tumor with grade group 5. And some of these cases expressed, as you can see, not only GATA3, but diffuse expression for NKX 3.1 that confirms the diagnosis of prostatic adenocarcinoma. I just want you to be aware when you have high-grade tumor, you will need to do more than just one marker to exclude or rule in or rule out prostate cancer. But the fact that GATA3 is positive in a high-grade tumor does not exclude the possibility of a prostatic adenocarcinoma, so you need to perform also another prostatic marker such as NKX 3.1 or PSA or P501S. This is instead another example of a liver metastasis from another tumor that is a prostatic adenocarcinoma, but you can see here that there is still glandular features that you can see in this microphotograph. High-power view, you can see also that is a tumor where there is a stratification of the nuclei and the presence again of these large, glands with lumen that is either round or elongated. Stratification of the nuclei. The nuclei are very tall and elongated. So this is an example of ductal adenocarcinoma of the prostate. You can see here the expression of NKX 3.1. PSA is also focally positive. So this is an example of metastatic prostatic ductal adenocarcinoma. You need to keep in mind the ductal type of prostatic adenocarcinoma because it's actually the one that preferably will go and have visceral metastasis. And sometimes they can present with papillary architectures. Ductal prostatic adenocarcinoma is an uncommon aggressive variant, represent about 3% of prostate cancer. Is clonally similar to the acinar, that is the common tumor of prostate cancer. We refer to prostatic adenocarcinoma. 97% of the tumor are acinar in nature. And the ductal adenocarcinoma is defined either by pseudostratified columnar epithelium that can be arranged in two major architectural patterns, either papillary, as you can see here, you have through vascular corrs, and cribriform architectures, where you have this complex glandular arrangement with closely opposing acini. They're showing these slit-like spaces, but sometimes they may be more like rounded, and multi-layering of the nuclei. These two major architectural patterns typically coexist, so you can have both the papillary and the cribriform together. Now, on radical prostatectomy, it's the term of ductal adenocarcinoma is reserved for tumors that have more than 50% of ductal morphology. Otherwise, you can have tumors that have both acinar and ductal component. On biopsy, adenocarcinoma with ductal feature is recommended because you don't know the overall presence. So you don't know if 50%, the tumor will make the cutoff of 50%. So if you find ductal features, you will say prostatic acinar and ductal, or prostatic adenocarcinoma with acinar and ductal features. Any proportion of ductal on a biopsy carries increased risk of biochemical failure and also metastatic disease. Keep in mind that ductal adenocarcinoma is also enriched for germline and somatic pathogenic alteration in the DNA repair gene, as I mentioned previously. And those tumors are less responsive to androgen deprivation therapy and have a higher propensity for the visceral metastasis. That's why we discuss it in here. Mostly they love to go to the lung, to the liver, and also to odd locations such as the testes. Ductal adenocarcinoma is equivalent to Gleason pattern 4 or 5, so this tumor would be graded as grade group 4 or 5, so Gleason pattern 4+4 or 4+5. Here's an example instead of prostate cancer on lung. So this is a lung tissue, and you can see this gland formation with, this would be in the differential diagnosis, you could think about also a colonic or of course at other type of tumors, but in a male, you need to consider the possibility of prostate cancer. So stains were performed, NKX 3.1 was diffusely positive. P501S, this is prostin, that is a prostate-specific marker, is also positive, and PSA was diffusely positive, supporting the diagnosis of metastatic prostatic adenocarcinoma. And I want to take a few minutes to discuss which are the best markers that can be used if you need help when you're making a diagnosis of metastatic prostate cancer. You can see that this was also published in 2014. At that time, NKX 3.1 was not as widely used as now, at least in the United States. Now, probably this is the preferred marker, although some tumors may be negative for NKX 3.1. That does not exclude prostate cancer. If you think that morphologically and clinically makes sense, you need to use other markers too. PSA is very sensitive in the metastatic setting and is highly specific. PSAP is also sensitive in metastases. P501S or prostin also, it's sensitive. But the studies are limited because this marker has not widely been used in many institutions. Now, the only things you need to know about NKX 3.1 that is highly sensitive in the metastatic setting, these can be expressed in lobular breast cancer. So in a male, of course, breast cancer is not common, but can be diagnosed. So you need to be aware of the fact that NKX 3.1 can be positive in lobular breast cancer. PSMA is also sensitive in metastases, but is not very specific. AMACR, of course, is not specific. I would not use this marker to make a diagnosis of prostate cancer since it's positive also in urothelial carcinoma and colonic carcinoma. ERG, as I showed you before in the metastatic bone lesion, is fairly specific. Is also a vascular marker, but in this setting is fairly specific, but the sensitivity is only 50%. Now, if you are considering, of course, other differential diagnoses, you may want to use a positive marker and a negative marker, like if you're thinking about the possibility of urothelial carcinoma, you may do a P63. If the tumor is diffusely positive for P63, it's not prostate cancer. So take-home points, we have discussed prostate cancer detection on CT and also the diagnosis on needle biopsy. We have also reviewed grading, the use of immunohistochemical stain to confirm the cancer diagnosis, and we have discussed the unfavorable pathologic features such as cribriform architecture and intraductal carcinoma. We've also reviewed prostate cancer staging on CT and also the staging on both needle biopsy and radical prostatectomy. We have discussed the biochemical recurrence prostate cancer. Sam has showed you, a case with osseous metastasis and also with lymph node involvement and the treatment effect briefly. And advanced visceral metastasis from prostate cancer, both from an imaging standpoint and also from a diagnostic standpoint on pathologic slides with the review of immunostains to confirm the origin of prostate cancer. So I want to thank you for your attention, and I want to thank you, Sam, for presenting the cases and for this radiologic and pathologic correlation. Hopefully you find it helpful, and we will be happy to answer any question that you may have. I noticed there is one on the Q&A. Somebody mentioned, thank you for the beautiful presentation. What stage of CAP do the urologists usually do on radical prostatectomy? What stage of CAP do the urologists do on radical prostatectomy? What do you think, Sam?
Yeah, I guess, the question is stage versus obviously grade group or whatever. A lot of urologists will start doing radical prostatectomies with grade group 3 disease or above. Stage wise, they prefer to have good outcomes. So any amount of pelvic nodal metastatic disease, even though it comes out, is somewhat nerve-wracking for them. That is one thing that we've been able, in high-risk patients now, we can get them in the United States PSMA PET scans to kind of improve potentially preoperative staging and better informed decision-making. But, seminal vesicle invasion and EPE are usually still okay for surgery, at least at our institution. I think they start questioning it once they start having advanced features like that, and the presence of nodal metastatic disease, even in the pelvis, while they do a lymph node dissection, does make everyone take caution.
Yeah, and I guess now, of course, I'm not a urologist, and it seems like from having been in different institutions, there's also some variability based on institution. And I believe it depends also on the patient, because we have a lot of high-grade prostate cancer patients now here at the University of Alabama, and I can see that, even some cases with high grade are, they will perform a radical prostatectomy. Now, as you mentioned, the metastatic disease may be one of the reasons where they would not use radical prostatectomy at that point. Let's see, please, do you have any word of us on risk factor to prostate cancer? Well, familiarity is for sure a risk factor. So I think patients that have a familiarity, particularly in a very young patient, needs to be followed up very closely. There are, of course, some genetic, like BRCA2, has been associated with an increased risk. And other things, I don't know, Sam, what do you think? What else can?
Yeah, I think there's, I don't know how strong some of the correlations are. I think there's work done on obesity potentially contributing. There's probably been something on microbiome. Prior, I'm sure pelvic radiation would put you at risk if you had a synchronous other kind of cancer. But yeah, no, that's not something I am admittedly an expert on.
But of course, it's a common disease, and the risk increases also with age. So, the older, of course, the patient, the higher the likelihood to find prostate cancer. Now, I think what is important is to distinguish between prostate cancer that would not kill the patient and prostate cancer that will kill the patient. So it's a matter also of, the grading, and if it's a low grade, like a grade group 1, probably these are patients that do very well and they don't require any additional therapy. But if you have a young patient with a very high grade group, these patients unfortunately do not do very well in the long run. And we see occasional patients with prostate cancer at a younger age. But yeah, in the United States, as you mentioned, obesity, I think, is also another important risk factor that may not be so prevalent in other places. I don't know if there's any compelling data on smoking. Of course, there's also data on diet, like for any other tumor. Any other question? I don't see anything else on the chat. I mean, not on the chat, on the Q&A. Does that mean that we were so crystal clear that nobody else has any question? If that's the case, I want to thank you everyone for participating, and thank you, Dr. Gargano, for working together for this presentation, and enjoy the rest of the day. Thank you.
Thank you.
And thank you, Dan Miller and ASCP, for giving us this opportunity. Thanks.